Welcome, my dear pulmonologists, to another video of Pulmonology Read Aloud. After I did my last video on pneumococcal vaccination recommendations, I received a lot of requests to consider influenza vaccination as well. So here I am with the latest updates on influenza vaccine and the clinical practice guidelines. So here I'll be discussing two main articles. One, which was published in the Journal of Genetic Engineering, which talks about the prospects of influenza vaccine and the basics of influenza vaccination. And the other is the 2019 guidelines, which were published jointly by the Indian Chest Society and National College of Chest Physicians. This hasn't been revised ever since, but it still holds a lot of importance even in today's time. Now, this guideline statement was basically a panel recommendation again, which was done by experts in Kolkata in 2019. And it usually comprises of multiple fields of experts. So this recommendation panel also comprised of 24 members and moderators, which included pulmonologists, diabetologists, immunologists, nephrologists from various parts of India. So let's get started. Before we begin to discuss about the influenza vaccine, just a quick recap of the influenza virus. Now, we all know that the influenza virus belongs to the Orthomyxoviridae family, and this family of viruses includes an enveloped RNA. So, it's an enveloped RNA virus. Now, these viruses have 8 segmented single strand negative sense RNA genome, and this RNA genome can be divided into either 7 or 8 distinct segments, which cause the subtypes. So subtype C and D, which is the 7 or 8 subtype A and B distinct segments. Now, this virus is prone to constant change through the phenomena of two main phenomena, antigenic drift and antigenic shift. And you would all remember that antigenic drift. So drift means a slight drift from what it is happening. So it's a minor genetic change which may be caused by a point mutation in the antibody binding sites, or it may cause the prevention of binding of the virus with the neutralizing antibody. But whenever we talk about a shift is a major event. So it's an infrequent major change in the influenza virus. And this includes new H and new N proteins. So there is a new influenza virus subtype. So this shift and drift is something very important in influenza epidemiology. And based on the monitoring of these changes, the severity of the disease changes, and if the changes are small, then we may already have a partial immunity. So we have a milder change in influenza. If it's a major shift, then it causes severe forms of disease. And hence, this is the backdrop of how our body reacts to the virus. So you can see in this picture, this RNA inside, and you can see the neuraminidase and the hemagglutinin antigens, the red and the blue ones, which are involved in the influenza antigenic shifts. There are 4 types of influenza thus based on what kind of HNN are there. Type A influenza, which usually causes the most serious epidemics. Type B influenza, which causes seasonal flu pandemics. Type C influenza virus, which causes mild flu symptoms. It has 7 antigens, and type 8, which causes animal infections, which has 7. So 8 in type A and B, and C and D has 7. So this is how the types of influenza are. And taking notes from this paper, we learned that there are 3 methods of creation of a vaccine for this influenza virus. So the 3 methods are: 1, we would inactivate the virus and use its vaccine. So an inactivated vaccine. 2 is a live attenuated vaccine, and 3 is a recombinant hemagglutinin vaccine. So the Global Health Organization, the WHO, and the stakeholders, they convene twice a year or biannually. They assess the virus's prevalence and they recommend a suitable vaccine to be used worldwide. Amongst the vaccine categories, now there are two kinds of vaccines, the trivalent vaccines and the quadrivalent vaccines. Now, as I said earlier, there's a lot of reassortment of the genetic material which causes the infectious virus strains from periodically appearing by genetic mutations. There's also reassortment of the genetic material between the human and the avian virus strains. So to cover that, various strains have to be included in the vaccine. So the trivalent vaccine, as the name suggests, has two strains of influenza A and one strain of influenza B. It is usually produced in chicken eggs. The quadrivalent vaccine has two strains of influenza A and two strains of influenza B. The quadrivalent vaccine is usually developed by recombinant technology. These are the commonly available influenza vaccines which are available worldwide. Take a close look at this chart and you will see the influenza vaccine inactivated vaccines with split virion, which are egg-based vaccines. They include the Fluarix quadrivalent, Tefluria quadrivalent, Flu larval quadrivalent, high-dose quadrivalent vaccine, which is still not available in India, the flu quadri from Sanofi, which is also available in India, Vaxigrip Tetra, Fluarix Tetra, they're all available here, Influvac Tetra, and Influgen produced by Lupin in India. So these are inactivated vaccines which contain a split virion and they are egg-based. There are also influenza vaccines which are inactivated, which contain the surface antigen and they have an adjuvant, adjuvated, and they are also egg-based. So these include the flu quadrivalent, which is available in America, and Agripal, which is available in India, along with Cadiflu-S, flu block quadrivalent, these vaccines. Then there are these subunit vaccines, subunit influenza vaccines, which are also inactivated vaccines, but these are cell culture based vaccines. So you see here, we've already seen three types of inactivated vaccines, the split virion, the surface antigen, and the cell culture based subunit influenza vaccines, the subunit vaccines, which again, the subunit vaccines, like in America, is available by the name Flucivlax quadrivalent. And then the live attenuated influenza vaccines, which even in India, one was produced by the Serum Institute, Nasovac S, and Flumist quadrivalent. We'll be talking about the various subtypes later, but let's just look at the guidelines first. So now, according to the guideline statement, the 2019 recommended statement, a lot of clarity was given into the available vaccines in India that one should prefer. So now there are two kinds of vaccines which are available mostly in India out of all of these. The standard dose trivalent inactivated influenza vaccine and the standard dose quadrivalent inactivated influenza vaccine. And there's also a third, as I said, the live attenuated influenza vaccine, which was made by the Serum Institute of India. Out of these, the first two, the standard dose trivalent and the standard dose quadrivalent, are recommended, but the live attenuated one is not routinely recommended. The reason for not recommending this is not that it was not beneficial. There is a robust safety data. It was actually studied very well of the nasal influenza vaccine, but there was no vis-a-vis comparative data on the effectiveness of live attenuated to inactivated. So that is why the panel recommends the inactivated. Having said that, there are certain special circumstances where a live attenuated vaccine may be used. So according to the panel recommendations, routinely you will not prefer a live attenuated vaccine, but maybe in future we will have more comparative data. Now, because the WHO keeps reviewing the prevalence data from all over twice a year, one in February and the other time in September. So based on that, these vaccines, the quadrivalent, trivalent, are also divided into the composition for a northern hemisphere and the southern hemisphere countries. So that is how we get a trivalent or quadrivalent vaccine for the NH or the Northern Hemisphere zone or the Southern Hemisphere zone. But again, I would say that safety of live attenuated vaccine was very reassuring from the data done in India, but there was less data to say whether it was as effective as the inactivated vaccine or not, and hence the inactivated vaccines are being recommended. There was some data though which showed that the live attenuated vaccine was slightly poorly effective against influenza A-like virus um, than the IIV, but it was very effective against influenza B virus. So we need to see whether it will be available in future. When you have both trivalent and quadrivalent, you would prefer a quadrivalent vaccine. So these are the WHO recommendations which are available, the northern hemisphere and the southern hemisphere, and this keeps changing every year. This is at the time of the publication of this article. However, we know that even now influenza, Northern Hemisphere influenza A, Brisbane, Kansas, Colorado, Phuket was then, and Michigan, Singapore, Colorado in the trivalent. And in the Southern Hemisphere, there was Michigan, Switzerland, Colorado, and Phuket. So, what is the current one now? So, the current vaccine that we have for this year, zero point 0.5 ml of inactivated influenza virus. I'm talking about the split virion vaccine. It contains influenza A Victoria strain and Thailand strain of 2022, which is the H3N2 like strain. And in the influenza B, it contains the Austria like strain of 2021 and the Phuket strain of 2013. And as you see, this vaccine that I'm showing here was propagated in hen's eggs from healthy chicken, and it is a heme agglutinin vaccine. So this is how this Southern Hemisphere vaccine for 2024 is available here. And similarly, there are the Northern Hemisphere vaccines. Now let's compare the trivalent and the quadrivalent vaccines. Now there have been data and studies to compare both of them. And if you look at the key observations from this publication in 2013, it said that the quadrivalent vaccine was highly immunogenic with a very good seroconversion of 91% against H1N1, H3N2 Victorian Yamagata strain, and also it offered improved protection against influenza B in children. The paper by Kininger et al. In 2013 again displayed quadrivalent vaccine with superior immunogenicity, and the same was repeated in 2013. So obviously it's very clear now that if a quadrivalent vaccine is available, that should be our first preference. Now, there is a lot of debate about whether we should be giving a Northern Hemisphere vaccine in India or a Southern Hemisphere vaccine. Now, geographically, India falls in the Northern Hemisphere, but it also falls in the tropical and the subtropical region, both of the Northern Hemisphere. So, in India, when you look at a latitude of 30 degrees, anyone who has 30-degree north latitude will have a different monsoon and a different winter season, and the ones which are south of the 30-degree latitude will have a different season. So those which are located north have a later monsoon, so the influenza peaks in the winters, and the cities which are south of the 30-degree north have peak seasonality in the summers between the July and September. So a lot of surveillance has been done of the influenza circulation, and it has been noted that usually though in most countries the influenza peak positivity, a 30% influenza peak positivity occurs in December to May, and in India, however, 70% peak positivity rate occurs in June to November. So India is against the typical NH pattern which we expect for a northern hemisphere. So for India, when we talk about influenza vaccine, we have to look at the local epidemiological data or the latitude within India rather than the WHO classification. So we could easily give even a SH vaccine in India. So, what is the efficacy of influenza vaccine when we give it? Often patients would come and ask that, is this going to protect me against influenza completely? Or I did receive a vaccine, but I still am suffering from influenza. And as physicians, it's important to clarify those doubts. So, the overall efficacy of this vaccine is around 60%, which is kind of a moderate efficacy. However, it's important to tell them that the key strategy for vaccinating is to control a severe disease and control the consequences of the disease. So it's very important that the population still receives the vaccination despite 60% efficacy. Who should not take a vaccine? Ideally, anybody who has severe allergic reaction to any component of the vaccine. And as we see, the main component of the vaccine that we are worried about is the chicken eggs, or because it's being propagated in fertilized chicken eggs. Other than that, there are inactivated by formaldehyde and sodium deoxycholate and filtered. So these are not the major constituents. The major constituent we're worried about is egg. So there are been a lot of times where I'm sure you would have faced them too, when a patient would have an egg allergy and we're wondering if we can vaccinate them. So ideally, the recommendations mention that if you have a history of egg allergy, so you must have a history of egg allergy, and you just develop urticaria by having an egg, then you can vaccinate with any of the vaccine, whether it's inactivated or live, if you just have an urticaria with egg exposure. If you usually have an egg allergy in which you have symptoms like you've had angioedema, you've had respiratory distress or vomiting, or you've required an emergency visit because of egg allergy, you can actually still take the vaccination. And there's normally the universal precaution protocol is that you don't require a post vaccination observation even if you're egg allergic. So you can still take the vaccine if you've had some symptoms of severe allergy, also like angioedema, on occasions. But if you every time have a severe reaction to eggs, and you note that you cannot take eggs, or you are at a very high risk of allergies, then you should not vaccinate yourself with vaccines propagated on hen's egg. Also, for Guillain-Barre syndrome, for experts say that if somebody does not have a very high risk of influenza complications, but have had Guillain-Barre syndrome within the 6 weeks of previous vaccination, we should not give them a vaccine because they are not at a too high risk, so we should not risk Guillain-Barre syndrome, right? So this is something which usually comes across, and there is latest data that even patients with egg allergy can receive inactivated vaccines. There are certain other conditions where we have to be careful. So patient on antivirals, can we vaccinate? Yes. Patients on statins, can we vaccinate? Yes. And why are we talking about statins? Because they have a propensity to reduce the effectiveness of vaccine, which is the influenza vaccine. Patients with multiple sclerosis, and I recently came across such a patient who's a known case of multiple sclerosis, and she asked me, Doc, can I take the vaccine? So yes, we can give a standard dose of inactivated influenza vaccine. And why are again we talking about multiple sclerosis here? Because some there is some evidence that vaccinations can have a detrimental effect on disease progression in multiple sclerosis, but evidence shows that influenza vaccine does not do that. And patients with steroids, can we vaccinate? Yes, like our COPDs, we must definitely vaccinate. But it has also been seen that steroid therapy can reduce the effectiveness of the vaccine. But it is safe to be vaccinated for patients who are also on steroids, like COPD patients. Coming to co-administration, another common practical issue. We know that inactivated influenza vaccine can be concomitantly or sequentially. So concomitantly in the same sitting in another arm, be given with other inactivated vaccines or with live vaccines, grade 1A recommendation. For live attenuated vaccines, experts recommend that you must have a 4 weeks gap between a live attenuated influenza vaccine and any other live vaccine. The live attenuated influenza vaccine does not interfere with the immune response of MMR or varicella vaccines. Hence, experts recommend that they can be recommended at the same visit. So, a live vaccine with MMR or varicella can be given together. And injectable vaccines, if you're giving concomitantly with influenza, make sure that they are different anatomical sites. So it is well tolerated, and there are no immunogenicity changes in people above 50 years when you give them at different anatomical sites. So you can give inactivated influenza vaccine with herpes zoster, and you can also give it with conjugated and unconjugated pneumococcal vaccines that we use commonly. Coming to storage, safety, and handling. This is something which is very, very important, especially when you're giving the vaccine in your clinic setup or you're giving the vaccine in, say, a camp setting. It's very important to keep the influenza inactivated vaccine at a temperature range of 2 to 8 degrees Celsius. The average temperature should be around 5 degrees Celsius. The vaccine should never be frozen, and it should not be stored in the door of the refrigerator where the temperature fluctuations can occur. So that is why you should not keep the vaccine in a household refrigerator, because the temperature uniformity keeps changing and obviously there may be power outages. So when you're using it in a clinic setup, a dedicated refrigerator with a temperature control is very important. And when you transport your vaccine, then the experts recommend that cold chain should be used and immediately the vaccine should be transferred to a refrigerator. So this is something which is very important, and a certified and a calibrated thermometer should check the temperature of the refrigerator at least once every day. And um, it should be adjusted slightly if the thermometer indicates that the temperature is, towards the extreme. So this is something which one should take care of. Coming to dose and frequency, a common dose of 0.5 ml is recommended for adults as well as children above 5 years of age. The experts recommend a single dose, not multiple, but just one single dose of influenza inactivated vaccine. We don't have the high dose inactivated influenza vaccine, but there have been studies where there was a better antibody response with a high dose vaccine. So, whenever it's available in India, it would be preferred. For now, since we just have a standard dose, then that can be continued. In view of less evidence which compares a single dose vaccine with a biannual vaccine, the experts in India have recommended annual vaccine only, so just once a year rather than repeating it. However, there have been studies and data to see whether there will be any change if you use it biannually. So let's look at the proposed region-wise vaccination timing in India. Now we know that for those cities which have a temperate seasonality, the preferred timing is September to October, like Srinagar, Chennai, and Vellore. For those cities which have a peak monsoon seasonality in July, for them, since the monsoon is in July to September, vaccination should occur much earlier in April and May, like in Delhi, Lucknow, Kolkata, Pune. So this is how vaccination timing will differ within India as well. These are the recommendations for influenza vaccination in various age groups. So people 18 to 49 years of age, one dose of inactivated vaccine annually, and this is based on the doctor. So it is a prophylactic vaccine. For those above 50 years, it's strongly recommended one dose annually. This is a recommendation for high risk adults according to the guidelines. So here you see that who are those who are at high risk. So these include diabetics, renal disease patients, liver disease patients, heart disease, heart failure, congenital heart disease, CCF, patients on long-term steroid, neurological conditions, hematological conditions, HIV, cancer, healthcare workers, doctors, nurses, paramedics, all medical paramedical personnel working in casualty, emergency, all personnel working in screening centers or managing high risk patients, lab personnel, drivers, staff of vehicles, ambulance, they all must be vaccinated with 1 dose annually. Again, pregnancy is a high risk condition and a single dose on annually recommended for all pregnant women. And another point to note is that the vaccine can be given in any trimester of pregnancy based on the seasonal strain. So this is the recommendation for high risk groups. What are the recommendations for special groups? It's been specifically mentioned in the recommendation statement that Hajj pilgrims or those who attend mass gatherings, they must be vaccinated, irrespective of whether they were vaccinated earlier or not, especially when they are going to another part of the world, because again, people from different geographical regions will be coming there. So that will affect this influenza seasonal activity there. So they must be vaccinated at their irrespective of their home place. Based on the place of visit, they must be vaccinated. And the currently circulating strains at the travel destination should be implemented, and this should be done 2 weeks prior to the scheduled departure. And that's really, really important. What is the high risk group according to the Ministry of Health, Family Welfare in India? Again, healthcare workers, as we said, pregnant women, chronic illnesses, children with chronic illnesses, and desirable for elderly above 65 and children 6 months to 8 years of age. It also is suggested in this recommendation that there should be an inclusion of veterinary people, poultry workers, and military personnel in this high risk group. So this brings us to the end of the recommendations, the panel recommendations for influenza vaccine. If you have any more questions, please feel free to write in the comment box. Stay tuned for another session of Pulmonology Read Aloud. Coming to the bonus content. Now, the bonus content after we finish the recommendations is how are these live and inactivated vaccines actually produced and what do they mean? Because clinically, when you come across so many types of vaccines, you must know which one means what. So if you take the whole virus, the live attenuated influenza vaccine, how is it produced is that you either take a less virulent strain of the influenza virus and use it for vaccination, or by manually passing a so-called parental influenza strain or parental influenza virus multiple times in a virus susceptible cell like a chicken egg, embryonic chicken eggs, or other process, and make this virus less virulent and then inject this less virulent virus, which is actually a live virus. The other way is to use an inactivated vaccine. So inactivated vaccines can have all the components, which becomes a whole virus inactivated vaccine. So basically a dead virus. So what you do is you again cultivate the virus in the chicken embryo, and once it proliferates, now you kill it by either inactivating it with heat or treating it with chemical reagents like formalin. And now the virus cannot multiply and it cannot proliferate, and so it will not infect the cells, but you still are using the whole virus, which is in inactivated form. The third way to prepare a vaccine is a split virion vaccine. Split virion. So what are we doing is we are cutting open this virus. So we split the virus. So some splitting agents are used and splitting conditions are used, which will disrupt the envelope of the virus and it will split open the virion particles. Now these splitting agents and nucleic acids and the large molecular weight proteins which are then produced will be discarded. So once it's split, all the agent and what we don't need will be discarded. The nucleic acid will also be discarded of the virus, and only HANA, the hemagglutinin, neuraminidase, and part of MNNP proteins, which are the active antigenic components, will be taken. And this will be called as a split virion vaccine. So we will take hemagglutinin, we'll take the neuraminidase, we'll take the matrix protein, we'll discard the viral RNA, we'll discard the heavy proteins, and then we will introduce it into the body. So we are using just what we want. And this will be a split virion influenza vaccine. Now, based on this split virion vaccine, another way that you can go about is to do the subunits. So you can have the subunit components, a subunit vaccine. So subunit is based on the split virion vaccine, for which the hemagglutinin and neuraminidase antigenic proteins are further extracted, and then they are purified and they are concentrated. So now you will are leaving the matrix protein, you're just taking the HN proteins, you are purifying them, concentrating them, and then you add adjuvants. So here an adjuvant is added. So adjuvant is added and the final subunit vaccine is produced. And sometimes these subunits may be polysaccharides, sometimes these may be the proteins in different vaccines. And you can also use a virosome subunit vaccine, so where virosomes are also added. So this is what the basic terminology means. Now, let's try and understand a few major points about these. So if you're taking a live attenuated vaccine, you're taking the live virus, which has low virulence, low pathogenicity, and it will allow the virus to infect the patient. And sometimes even a low virulent virus can proliferate because it's still a live virus and proliferate in a relatively short time. So this is actually potentially a danger because it can evolve its genome into the parent-like virus. So somebody who's very immunocompromised, we would not use a live vaccine because there may be a process of genetic reversion where this may become like the parental virus. So this may present a potential risk, but they can also induce local immunity or mucosal immunity along with humoral and cellular immunity, so may actually give a good immune response. So if live virus vaccine is not what we want, then we take the inactivated. As I showed, one way is taking the whole virus. Now the whole virus, you're using fertilized chicken eggs to produce. Secondly, because you're using adjuvants also in like in split virion subunit, you may increase the immunogenicity. Because the virus is dead, the safety profile is good and the immunity duration is long and there's no risk of reversion because the virus is deprived of virulence, deprived of transmissibility, and the complete package or the complete antigenicity given by the surface protein antigens and the rest of the parts is being used. So they can produce humoral immunity and a very high titer of specific uh, antibodies. However, because they have the whole virus, they have the envelope, they have everything, they can induce certain side effects. So adverse events are more like high fever in children. So these vaccines are not actually recommended for people less than 12 years. So this is the problem with using everything because even unwanted things are coming in. So what do? We purify it further and we split it. So we can use a split virion vaccine, which will splitting open the viral envelope, concentrating the active antigenic proteins. So this causes maximum antibody production, less side effects, and it's safer than a whole inactivated vaccine. And as I further showed in the previous slide, the subunit vaccine, where you're more purifying the HA protein and NA proteins with good immunogenicity, safety, tolerability, but it said that the immunogenicity is still lower than a split virion vaccine. And it may have a higher cost because you're using more processes to purify. And in epidemics, you may actually use 2 doses. So you may need more doses of this highly purified vaccine to serve the purpose. So I hope that with this, it's quite clear what we are dealing with, which vaccine is doing what purpose. And Dr. Ravi requested me to have a slide on the currently available vaccines in India. So this is what it is. We have Zydus, Abbott, Sanofi, and GSK vaccines being used. Vaxiflu 4 by Zydus is an inactivated split virion quadrivalent vaccine. Influvac Tetra is an inactivated surface antigen quadrivalent vaccine. It is a subunit vaccine, the only subunit vaccine. Fluquadri Sanofi is also a split virion quadrivalent, and Flurix Tetra by GSK is also split virion quadrivalent. There are few vaccines that are not commonly available though, but these are the most commonly available that I found. If there's any more vaccine that you found, please let me know. And thank you for listening, and I hope this video was helpful. Keep subscribing and liking. and sharing Pulmonology Read Aloud. Thank you very much.